Hello, this is Ruth Winecker, and I'm going to talk to you today about what's new in forensic toxicology, drugs, and standard setting. We have a brief outline. I'm going to talk about some background and framework about what we're going to discuss today. I'm going to talk about the various ways that standards are set in forensic toxicology, and then I'm going to use some case studies to help you understand what can happen when standards aren't followed or shortcuts are taken, or even with the best intentions, when standards are followed, how things can still go wrong. So forensic toxicology is a multidisciplinary field involving the detection and interpretation of the presence of drugs and other potentially toxic compounds in bodily tissues and fluids. These analyses and interpretations are conducted in a manner to be defensible in court. These include postmortem forensic toxicology, which determines the absence or presence of drugs in their metabolites, chemicals such as ethanol and other volatile substances, carbon monoxide and other gases, metals, and other toxic chemicals and poisons in human fluids and tissues, and evaluates their role as a determinant or contributory factor in the cause and manner of death. Human performance toxicology determines the absence or presence of ethanol and other drugs and chemicals in blood, breath, or other appropriate specimens, and evaluates their role in modifying human performance or behavior. And then forensic urine drug testing determines the absence or presence of a usually limited number of drugs and their metabolites in urine to demonstrate prior use or abuse of a drug. So I'm going to cover some definitions here so that will frame what we're going to talk about. So a best practice is a method, technique, or process that has been generally accepted as superior to any alternative because it produces results that are superior to those achieved by other means. A minimum practice standard is generally used to improve the overall practice of a field and bring all methods, policies, and procedures up to a minimum level. A guideline is a formalization presented by a technical society or government agency as basis for voluntary adherence for acceptance of a work product. Guidelines state the basis for an acceptable product or process. In general, guidelines use the words should when stating what should be done. A standard, by comparison, is more rigidly defined with less room for interpretation or extrapolation into a situation. The standard exists only following a process of testing and peer review, and in some fields, this process can be very formal and extensive. To claim a certain level of quality or achievement for a particular practice, one is required to follow the standard, and language used in the standard is shall. You shall do this, not you should do this. Standard setting in forensic toxicology has actually been around for a long time and largely preceded the National Academy of Sciences report on forensic science in the United States. In 1982, Osaka Lab accredited their first crime laboratory. And in 1986, the National Laboratory Certification Program developed standards for accreditation for laboratories performing workplace drug testing on the behalf of HHS, or Health and Human Services. In 1991, SOF, which is the Society of Forensic Toxicologists, and AFS, which is the American Academy of Forensic Sciences, developed laboratory guidelines. And the first version in 1991, and then following with new versions in 1995 and 2006. NAME, which is the National Association of Medical Examiners, had previously accredited medical examiner offices prior to 1995, but they did not do it on a checklist. It was a peer review at that time, and then their first checklist was developed in 1995. The American Board of Forensic Toxicology, which is ABFT, accredited their first medical examiner laboratory in 1997. In 1999, ANAB, as ASCLD Lab, took all of their checklists and assessed laboratories to the ISO standard 17025. Finally, in 2009, the National Academy of Sciences report was issued on the state of forensic sciences in the United States. And it was largely critical of many practices, although toxicology did get a passing grade. In response to that, the SWIG-Tox was formed, which is a scientific working group in toxicology, and they began the first work on setting standards for forensic toxicology, including guidelines and standards, using those shoulds and those shalls. And in 2015, the Forensic Science Standards Board and the Organization of Scientific Area Committees was founded at NIST. This is 25 forensic disciplines, specific groups, divided among 5 scientific area committees. In 2018-2019, the Academy Standards Board, a standard developing organization, published 2 toxicology standards. And there's actually 9 further in line. And in June of 2019, the OSAC approved the first of the toxicology standards that are going through that process. Workplace drug testing has a long history of setting standards. President Ronald Reagan established the Federal Workplace Drug Testing Program in the 1980s, and currently 117 federal agencies are covered by the urine mandatory guidelines in accordance with Executive Order 12564. This executive order currently covers approximately 2.2 million executive branch employees and job applicants. And these employees are subject to annual testing or random testing and are all subject to reasonable suspicion testing for suspected drug use. The Department of Transportation also utilizes the urine mandatory guidelines in its regulatory testing programs, requiring testing of over 10 million safety-sensitive employees and applicants in DOT-regulated transportation-related industries nationally. The Nuclear Regulatory Commission also uses laboratories that are accredited by these guidelines to test an additional 2 million employees and applicants. In this private non-regulated sector, 20 to 50 million Americans are tested as applicants or employees using some aspect of the urine mandatory guidelines. As such, 6 million plus specimens are tested each year under the National Laboratory Certification Program. This program provides comprehensive laboratory quality assurance and guidelines in order to ensure the accuracy and dependability of employee drug testing programs. It includes verification of laboratory procedures, inspections, and audits. 10% of all non-negative specimens that are tested each year by these accredited laboratories are audited. It includes proficiency testing, including all analytes tested under the mandatory guidelines, and including common interference and simulation of special issues. This is considered the gold standard in forensic urine drug testing. Many aspects of the mandatory guidelines are incorporated into checklists and standards developed today for other forensic toxicology testing purposes. Standards, however, are not static. You just don't set them and go. There is a review process that occurs on an annual, semi-annual, or a 5-year basis, depending upon the standard. In the forensic urine drug testing, urine mandatory guidelines, over the years, changes to the standards include development of specimen validity testing to overcome and in response to a plethora of products designed to thwart the drug testing procedures, allowing for biomarker testing to validate the specimen as biologically produced urine rather than synthetic urine, and then new standards allowing for alternate initial testing technologies, since many adulterate disrupt immunoassays used for initial testing. The American Board of Forensic Toxicology's objectives of the accreditation program are to establish, enhance, and maintain standards of qualification for those laboratories that practice postmortem forensic toxicology or human performance toxicology. They accredit these qualified laboratories to comply with the requirements of the board. In this way, the board aims to establish a practical and equitable system of readily identifying laboratories that have demonstrated the requisite qualifications and competence in forensic toxicology. The accreditation is based upon compliance with professional standards as assessed by peer review and a checklist. Again, it's a continually evolving checklist. Analytical methods in 2014 were required to determine ethanol using a 2-column GC method or alternate method equivalent or greater forensic strength. That would include mass spectrometry. And then the newest checklist is under construction in 2019 right now. But why would we want to do that? This is an example of a 2-column method. As you can see here, methanol, ethanol, and other volatiles elute in a certain order on the first column, but on the second column, they elute in a different order. So you have a switching of ethanol and acetone in the second column. That's important because there are other volatiles. As you can see here, this is a case example where there appears to be a peak for ethanol, but in actuality, on the second column, you can see that peak is moved and it doesn't confirm for ethanol, and that's actually ethyl chloride, a commonly abused volatile. The Organization of Scientific Area Committees, as I mentioned before, is a group of forensic practitioners and other individuals, including universities, researchers, consumer manufacturers, and there are 25 discipline-specific groups among 5 scientific area committees. The toxicology group is part of the chemistry instrumental analysis group. The toxicology group subcommittee is focused on foundational documents to improve the practice of forensic toxicology and assure minimum policies and practices are in place. For example, the standard for the analytical scope and sensitivity for forensic toxicology in drug-facilitated crimes has been developed to ensure laboratories are using appropriate cutoff and testing schemes for those cases, which are quite different than testing required for diagnosis of drug overdose deaths. In that way, it ensures laboratories that are handling multiple different types of cases are treating them differently as such and appropriately. Importantly, there will be a standard for education and training of forensic toxicology practitioners. And as we'll see later, just having a standard for how to do something is no substitute for properly trained and certified personnel. The National Association of Medical Examiners provides leadership and advocacy for best practice and excellence in forensic pathology and death investigation. Their checklist has a number of items that are applicable to forensic toxicology. These include, is peripheral blood rather than central blood used for toxicological testing whenever possible? Is the site of collection of the blood used for toxicology recorded? And also reminding practitioners that toxicology by itself should not be used as a substitute for forensic autopsy or a substitute for a careful search of a death scene for health and safety hazards. And when the toxicology is requested, the pathologist is required to make the toxicologist aware of the circumstances surrounding the death and any medications which may have been taken into by the decedent. That's really important, and we're going to use some case studies here to show. So one of the things that's really complicated about postmortem forensic toxicology are these things called pre-analytical challenges. That means before the specimen actually gets to the laboratory, things happen to the specimen that can cause problems with interpretation of the results that come out of the laboratory. In general, the specimens collected at autopsy are no different than any other specimens, although they may have deteriorated somewhat, but the process is still the same for analysis and reporting of concentrations. It's the interpretation that you have to worry about. So one of the key articles on this process is called the PreAnalytic Aspects in Postmortem Toxicology. You can see that reference here. But these are things that are brought up in this article are what I'm going to talk about in the next few case studies. These include sample integrity, postmortem alcohol formation, postmortem redistribution, site dependence, postmortem diffusion, trauma artifacts, and medical artifacts. This next, in medical artifacts, the two key things in the name checklist are when toxicology is requested, is the toxicologist made aware of circumstances surrounding the death and any medications which may have been taken by the decedent, and is a complete investigation done by the coroner or medical examiner. Here's a case where that actually didn't happen. So this was big in the news in this area of the country in which this young man died. And so there was an erectile dysfunction drug found in the toxicology unexpectedly in this young man after he died. He's only 16 years old. He's at a house party. He's drinking. And at autopsy, they find aspiration of the stomach contents. They find a pretty low ethanol value. And they also find papaverin, which is a erectile dysfunction drug. The coroner assigned the cause of death as asphyxia due to aspiration and other significant conditions of ethanol and papaverin use. The opinion exhibited by the coroner said that it's unknown whether the drug was being used recreationally or someone slipped it to him in a drink. Well, this was very hard on the family. They did not have any of this drug in the home environment. It made them feel like there was some foul play in their son's death, and it pressured the district attorney and sheriff's office to pursue looking into this death some more. So later on, it was found out that the papaverin was actually administered during tissue retrieval. So there was some organ donation after this death. And so the coroner was forced to reevaluate the situation and call the cause of death undetermined with other significant condition of ethanol use and give a likely explanation of asphyxia and get rid of the mention of the papaverin, since that wasn't even administered until after death. Another example of not telling the toxicologist what you're looking for and how that can affect what you find in the toxicology results is just a reminder that there's no such thing as a complete drug screen or a complete toxicology test. Toxicologists are really dependent upon the information that is presented to them, and it really is the key of garbage in, garbage out. Now, this is an old drug that I'm going to talk about next, but it's a really good example of what can happen and why you really need to keep those lines of communication open with the toxicologist. So oxymorphone was a new drug that had been approved by the Food and Drug Administration for individuals with severe pain, but as usual, opioids that are new on the market become target for abuse and diversion. So this is a young man that died in North Carolina after taking oxymorphone that he got from a friend. And this drug started showing up in the medical examiner cases in May of 2007. Both of these early cases were young individuals who really had no good reason to be dead and had a history of intravenous drug abuse. One had recent needle punctures. One had a history of snorting pink pills. And that was all the information that was provided to the toxicology laboratory. And all of the standard toxicology screens were negative. And it wasn't until we received a consult call on the first case, and the medical examiner was, this has to be a drug overdose. Why was all the toxicology negative? And then he proceeded to tell us that there was an Opana tablet found on the table next to the decedent. So that would have been very useful information to the toxicologist, because at that time in 2007, oxymorphone or Opana was an actual special test. It didn't come out in your regular screening test, and if nobody mentions it, then nobody tests for it. And that's what happened there. And it can happen with other more routine things, other more routine poisons. In this example of an insufficient investigation, this information wasn't even passed on to the pathologist, and therefore was not passed on to the toxicology laboratory. This individual had a history of suicide attempts. There was a suicide note on the scene, and a list of drugs was provided to the toxicology laboratory, but it was all negative. Finally, pictures of the scene were obtained from law enforcement, and we find that there's some Preston, which is antifreeze, which of course will cause a death if you drink it. But again, it's a special test. It doesn't come out under the regular screens, and it's sufficiently rare that laboratories cannot use the resources to screen every case for this particular poison. Unlike the oxymorphone, after it appeared on the scene, it was quickly added to the regular screens so that it could be picked up, and it was a very common drug that caused death in individuals in that time frame. So another one that I want to talk about is from the name standards is checklist is peripheral blood rather than central blood used for toxicology testing whenever possible. And then is the site of collection of the blood used for the toxicology recorded? This can be really important. Peripheral blood or femoral blood is really considered the gold standard in postmortem forensic toxicology, but it can have some problems. Here's an example of this postmortem redistribution, a good article for review for those that are more interested. But as you can see here, drug moves from areas of high concentration after death to areas of low concentration. And so you can get increases in drug concentration after death, and that can mess up the interpretation of the concentration or the implication as the cause and manner of death. Terminal aspiration is actually also very fairly common. In a methadone study of 331 cases showed that in 9.3% of the cases there was evidence of perimortem aspiration. And dying is stressful to the body, and this can happen at that time. Problems can occur if there's intact tablets in the stomach at the time that this happens, because you can also get gastric trapping of basic drugs in the stomach contents. But if you have an intact tablet, you could get 5,000 nanograms of drugs delivered in a nice, neat package to the lungs, and then it will diffuse from there, which will drastically increase concentration of drugs in the central specimens. So in this case, a 48-year-old white female has a history of ethanol abuse and recreational drug abuse. She has a bottle of 30 Xanax, which is empty, and aspiration of gastric contents. As you can see here, the subclavian blood, which we would consider, which is generally considered a specimen that's between central and peripheral, so it has concentrations that are that are lower than central but higher than peripheral. And then you see the femoral blood here, concentrations. You can also see how dramatically different these concentrations are between these two specimens. One of the problems here with aspiration is that the lungs are near the subclavian vessel, and if you take specimens from there, then you can get a lot of diffusion of the drug from the lungs. And if subclavian blood was the only specimen you took, you could be misled to believe that this is a suicide because these concentrations are indicative of that in the subclavian blood, but they're perfectly normal in the femoral blood. So that's why taking femoral blood is very important. However, things can go wrong with taking femoral blood or peripheral blood. And this is an example of that. This is a 14-year-old white male. The mother had missing oxycodone tablets. The autopsy was largely unremarkable, as you would expect in a 14-year-old, and the femoral vessel specimen was taken by external stick. Now, taking a femoral vessel specimen of blood is important and is considered the gold standard. However, taking it by an external stick is not. So as you can see here, the oxycodone, which is what the decedent was suspected have been taken, is quite high, and the metabolite, the oxymorphone, is low. And this is what you would think of as kind of a normal distribution. In the femoral vessel, however, they're practically equal, the oxycodone and the oxymorphone. And in urine, you see a normal distribution again. So there's clearly something wrong with the femoral specimen in this case, and it's only because we had these other specimens that we were able to see this. So the conclusion from the femoral vessel specimen could be that the decedent had gotten a hold of not only oxycodone, but oxymorphone, if a good investigation had not been done as well. So the interpretation of this is problematic. External stick femoral vessel collections can be very problematic as well. They can be contaminated with fat. They can be contaminated with diffused fluid from muscle, or if you hit that vein and you haven't tied it off, then you can pull down blood from more central locations, and that could also affect the concentration of the drug. So it takes it from being a gold standard specimen to a no good specimen. The specimen itself had a funny color to it. It looked kind of green, and we originally thought that maybe it was bile, even though it was labeled as femoral blood specimen. So we did a bile acid analysis, and you can see there that the femoral vessel bile acid was much, much higher than the aorta. But because there was a good investigation and because we had other samples in this case, the cause of death was attributed just to the oxycodone, because we showed that that is the most likely scenario, that the decedent had only taken oxycodone. This is a picture of the vessels showing you how they really are all connected. And if you pull down hard enough, you can pull blood from a more central location. One of the things that can also cause problems is, are you really designating where you got the specimen from? So some pathologists will say they got the specimen from femoral when they really got it from the iliofemoral area. and that's fine for most things, but some things it can be a problem with. In this particular case, we had a 51-year-old female. Her femoral blood pregabalin was what I like to call ginormous. It's really, really large. And the urine concentration is also quite large. But the aorta blood concentration of the pregabalin is normal. And in the graph to the left here, you can see the pregabalin distribution of the concentration. And you can see that almost all cases in postmortem, the concentration is between 5 and 9.7, and very, very few are much, much higher than that. So what's going on here? Well, the iliofemoral vessel is actually sitting there in that cavity right there, and the bladder actually sits right on top of it. And if the autopsy is delayed, you could get diffusion of that drug from the urine in the bladder right into that vessel, and you can get really high concentrations that occur from that situation. So again, if we had not had that central blood specimen, then we might have been led to believe that that was an overdose, and even an intentional overdose of pregabalin. So, and this is an example of specimens collected from a funeral home that, again, the note from the main accreditation checklist says that toxicology by itself should not be used as a substitute for a forensic autopsy or as a substitute for a careful search of a death scene for health and safety hazards. And this is no more true than in this actual situation. This woman had a history of some natural disease and problems, and heart blood was submitted to the toxicology laboratory from the funeral home. So the funeral home is the actual person that procured the specimen and submitted it to the medical examiner laboratory. Toxicology was requested, but the family objected. They said, if you're going to do these analyses, then we want you to do an autopsy. So this is what happened. The autopsy was performed and femoral blood was collected. What they noticed in autopsy was there were 4 needle punctures in the thoracic area. And that means that the individual in the funeral home had a difficult time collecting a specimen. There also was noted aspiration of the gastric contents. At the autopsy, you could see that. They found some pancreatitis and some other minor natural disease findings. And the specimen, the thoracic puncture specimen, also didn't look right. It was kind of brown and icky, and so they sent it off for microscopy to look at it. And what happened was they found there was meat and other things. So clearly what happened at the funeral home was that the individual procured the sample, had difficulty getting the sample, and probably punctured the stomach, and that's what part of the sample actually was. As you can see here, the thoracic puncture concentrations of these drugs, including ethanol, are quite elevated, and they look like a acute, massive ingestion of the antidepressant amitriptyline. But when you look at the femoral blood specimen, there's no ethanol. And one of the reasons for that is that if you have aspiration of gastric contents, you can aspirate some bacteria, which will then merrily go along their way and produce some ethanol. There is no real ethanol in this case. All of that is a postmortem or pre-analytic artifact. And the amitriptyline concentration and the nortriptyline concentration are perfectly normal in this case. So this is a natural death. But had the only specimen that had been submitted been the thoracic puncture specimen, it might have been led, the conclusion might have been quite different and would have had really bad consequences for the family in this case. So I'm going to finish up here with some talk about, what's going on new in toxicology and what these new standards are going to do to help us. So it's no secret here that drug deaths have increased dramatically in the last 10 years or so, and exceeded motor vehicle crashes as a cause of death quite some time ago in that time frame. This is largely due to illicit medications, opioids, and new and novel psychoactive substances, including fentanyl analogs. So if you look at the top 5 drugs poisoning by year, way back in 2000, 2001, heroin was in the top 5, and then it dropped out, and it was mostly prescription medications, but then it came back again. The fentanyl that you see here in red is all prescription fentanyl. So this is all Duragesic and other prescribed medications that were largely being diverted and then abused. But the fentanyl in green here is illicitly produced fentanyl. And then the blue is the fentanyl analogs. So the emerging threat report from the Drug Enforcement Agency is indicative of how common this problem of fentanyl and fentanyl analogs are largely in 2016 and 2017, there were a large number of fentanyl analogs that were identified along with fentanyl in substances that were submitted for analysis by the DEA and the crime laboratories. In 2018, that changed a bit. There were a large number of identifications of fentanyl, but there was a lower amount of identifications of related substances. And you can see that here in these graphs. So in 2016, there's a large number of 877 of fentanyl and 142 of furanylfentanyl. And then down the line, you can see the other analogs that were identified. And in 2017, same thing, a large amount of furanylfentanyl and other analogs and other designer opioids are identified, and a fair number of them as well. But in 2018, you can see it mostly goes to fentanyl here. A big number of fentanyl. And then the two next most common items, the 4-AMPP and the acetylfentanyl, are actually produced. 4-AMPP is a precursor product that is used to illicitly manufacture fentanyl, and acetylfentanyl is believed to be a byproduct of the manufacture of fentanyl. So these aren't separate things that are identified in separate submissions to the laboratory. These are things that are identified with the fentanyl in the laboratory. In February of 2018, the DEA placed all analogs of fentanyl not already scheduled onto Schedule 1. An analog can be defined as any substitution along the main backbone of the fentanyl, better known as 4-AMPP, and you can see that here. Addition of a 3-carbon carbonyl group makes fentanyl. Removal of just one carbon from that chain makes acetylfentanyl, commonly found as a byproduct of illicit manufacturing. Addition of a fluorine in the para position makes parafluorofentanyl. Substitution of a benzyl group with a thionyl group makes thionylfentanyl. And then addition of 2 carbon and oxygen to the 3-carbon carbonyl group makes furanylfentanyl. Finally, additions and substitutions along the whole backbone make alfentanyl, which is closely related to the really scary molecule carfentanil. Basically, any new compound with a substitution or addition along this backbone will result in immediate Schedule 1 placement. The OSAC Toxicology Subcommittee is working on a standard for identification in forensic toxicology. It's actually published on the NIST website in order for laboratories to take a look at it and, kind of kick the tires on it and see how it works in their own laboratories. So it's based on a point system. So there's a minimum number of points required for a positive identification of an analyte. There are points that are greater based on the specificity of the technique. So a high-resolution mass spectrometer gives more points than a low-resolution mass spectrometer. And also stated in the standard is when known isobaric and isoptomeric compounds exist, they should be evaluated during method validation. Well, with the plethora of specimens that have been coming out and being found in forensic cases, you're not going to know, right, what is coming along, and you're not going to be able to evaluate all of those things before you put a method online. So that new and novel psychoactive substances epidemic has presented many challenges for forensic toxicology labs performing general unknown screening. Here's an example. The standards can't really replace due diligence and experience. So down here on the left is fentanyl, and up on the top right is paramethylacetylfentanyl, and down on the bottom right is alpha-methylacetylfentanyl. All of these molecules have the exact same molecular weight. And so using a high-res instrument is not going to get you an identification necessarily. The Paramethylacetyl fentanyl will give you a different structure when you analyze that molecule by either high-res TOF or Orbitrap or even LC-MS from the fentanyl and the paramethylacetyl fentanyl. However, with the fentanyl and the paramethylacetyl fentanyl, both of those techniques, even though both are give more specificity and you get more points in those techniques in the system, give you the same product ions. So the only way to tell the difference between these two molecules is to either use a different technique, GCMS, which gives the same major product ion of 245, but a differential ion of 146 for fentanyl and 160 for paramethylacetyl fentanyl. So what happens here, though, is that you can't expect standards to prevent all errors in a lab. Several cases positive for the analog, the paramethylacetyl fentanyl, were identified as fentanyl by Orbitrap high-res MS and confirmed by LC-MS because the retention time and the product ion ratio criteria were met. Only on final review, noticing that fentanyl was not detected by a third method for screening organic bases by GCMS, and the paramethylacetyl fentanyl was detected, prevented reporting the wrong drug on the toxicology report. However, labs doing targeted analysis using immunoassay for fentanyl and LC-MS for confirmation testing for fentanyl would be vulnerable to reporting cases positive for fentanyl when it's really paramethylacetyl fentanyl. So clearly, education, training, and certification of personnel are integral to the quality forensic toxicology process. That's all I have today for you. I just wanted to tell you about what's new and what's happening in standard setting and improving the forensic toxicology field. Thank you very much.